Dr. Rubin is going to be our moderator for the next panel. And then in addition, I want to introduce our other panelists, and that's my partner in our practice downtown at Phoenix at the University Medical Center there, Dr. Hagen. So Dr. Hagen is a rhinologist like myself.
Thank you so much. Good afternoon. This is probably the first time you're going to see a Wolverine, a Buckeye, and a Fighting Irish, right, on the same panel. And there is a 4:30 p.m. kickoff between Notre Dame and Michigan, so I get out of here. So just briefly, I was asked to talk about the relationship between allergic rhinitis and asthma. And this also ties in with upper airway inflammation, including chronic rhinosinusitis. I have no potential conflict of interest. So allergic rhinitis and asthma, we know, frequently coexist. Allergic rhinitis is a risk factor to develop asthma. And allergic rhinitis is present in over 80% of patients with asthma. So for this talk, we're talking about the most common phenotype, which is allergic asthma. We formerly called it extrinsic asthma. And asthma is present in up to 40% of patients with allergic rhinitis. They share key elements in terms of epidemiology, pathophysiology. And so there's a concept called the United Airway Disease concept, where allergic rhinitis and asthma might be the same spectrum of the same disease process. So I want you to think of the upper and lower airways as one disease. So when you're treating upper airway inflammation, sometimes the patient also has coexisting asthma. And they share common histologic structures. I'm not going to go into this. You have the slides. The most common thing is the Th2 inflammatory process, which nowadays we focus on with all the biologic agents that are out there. The Th2 inflammatory process is the IgE-mediated hypersensitivity response to non-harmful proteins, which are known as airborne allergens or aeroallergens, pollens, pet dander, dust mites, molds, etc. And the inflammation involves cytokines, leukotrienes, and histamine, and that's where we're targeting treatment options. If you take inflammatory cell infiltrates from the upper and lower mucosa, they're similar, and they have similar treatment options. And the most important thing is in the patient with asthma and coexisting, or allergies and coexisting asthma, is adequate treatment of allergic rhinitis and or chronic rhinosinusitis actually will decrease the frequency and severity in their asthma symptoms. They'll have fewer exacerbations. The nose protects the lower airway. It humidifies the air, cleans the air. It has innate and adaptive immune defenses to protect against pathogens entering the lower airway. And so in allergic rhinitis, if you get mouth breathing from nasal congestion, this has an adverse effect on asthma because now you're going to breathe in cold air through the mouth. It's not going to be humidified through the nose, and you get bronchoconstriction. Also, it can allow pathogens to enter, which is also due to decreased nitric oxide levels. So then you can get asthma exacerbations. And postnasal drainage, you can have inflammatory secretions going into the lower airway, can cause more asthma symptoms. And then the last point is controversial, whether there's a nasobronchial reflex. Treatment options are the same. Allergen avoidance is key. Pharmacologic therapy involves, the mainstay is the intranasal steroids for upper airway inflammation, so Flonase first line, even before antihistamines. In the case of Dr. Hurley, it would be Astelin. And for asthma, also inhaled corticosteroids. My favorite is singular, if you don't have too severe of asthma, because it blocks both upper and lower airway inflammation. And then, even though antihistamines and intranasal steroid sprays are not indicated for lower airway asthma disease, again, you'll get improvement in their asthma symptoms, which may be due to decreased bronchial hyperresponsiveness or because you get improvement in their nasal obstruction with less mouth breathing. And then immunotherapy, that's desensitization, allergy shots. It's considered the only treatment that can prevent asthma development. So if you have a child that just has hay fever, you put them on shots. Hopefully they will not develop lower airway inflammation going on. And they also prevent new sensitizations. So if you're only allergic to cat and grass, let's say as a kid, you're only on shots to cat and grass, they're not necessarily going to develop further sensitizations to dust mites or dogs moving forward because you're actually altering their immune system, changing them from the Th2 paradigm to the Th1. And finally, biologics. This is my bread and butter. I love how allergy immunology has evolved. When I was in fellowship 18 years ago, Xolair came out. So that I've been using for years, but it's only approved for urticaria and asthma. Now we have a few others that are targeting different parts of the Th2 inflammatory pathway. Sorry, this is just schematic, but we have the anti-IL-5s, the anti-IL-5 receptors, and I don't know if this works, but the anti-IL-4, IL-13, which is dupilumab or Dupixent's the brand name. That was initially approved for atopic dermatitis, got the indication for severe persistent asthma. So I've been using this for years. We knew that it would help target the upper airway because of blocking, down regulating the Th2 inflammatory process, eosinophilic inflammation. So we have patients, even before it got approved for nasal polyposis at the end of June, that had been on it either for atopic derm, and polyps was the real reason I started them on it, or asthma, and their polyps actually went away. So those are the key points. You guys have it in your syllabus, but basically treat both upper and lower airway inflammation together. Quickly, I was asked to just provide a case presentation of a patient with an acute asthma exacerbation. So I have a 46-year-old female. She has a history of moderate persistent asthma and allergies, and she presented to me with complaints of bilateral maxillary sinus pressure with upper teeth pain for 2 weeks after she spent time outdoors at her son's soccer game. She was status post vitamin Z per urgent care, and this did not provide any relief. It subsequently propagated into her chest. She was wheezing, coughing, she had chest tightness, she couldn't sleep because of coughing when supine. She was using her albuterol inhaler 4 times a day, and that was despite being on Symbicort, the high dose 2 puffs BID with Singular. So on examination, she was not in any apparent respiratory distress. Her O2 sat was normal, although she usually was 100% on room air. She was 96%. She did have some sinus tenderness to palpation, hypertrophic erythematous nasal turbinates with some cloudy white to yellow mucus. And her lung exam, she had faint and expiratory wheezes bilaterally, which was worse at the bases, and she coughed a little bit. This is hard to see, but you have it, the slide. This is her office spirometry, so her FEV1 was 70%. So she's obstructed, and this 41% that I circled, that's the lower airway, the FEF 25 to 75%. So she's definitely having obstruction and small airway inflammation. We give her 2 puffs of albuterol, and she has significant reversibility. Remember, reversibility criteria is 12% or more. So her FEV1 went up to 17%, and the FEF 25 to 75 went up to 29%. And so treatment, what I did was, because she still had sinus symptoms and evidence of acute rhinosinusitis, I gave her a 10-day course of Augmentin, 875 twice daily. Short bursts of prednisone. When they have both upper and lower airway inflammation, I do 20 BID for 5 days. She was advised to continue her Flonase and her Singular, and I also prescribed budesonide respules with albuterol nebulizer treatments to use twice daily in place of her Symbicort for the next week as there's better penetration of the airways. And I recommended symptomatic therapy, fluids, rest, Neomed, sinus rinses, steam, Mucinex if needed. And because I'm such a fabulous physician, she followed up and was completely resolved 10 days later. Thank you.
All right, I get the fortune of giving the last talk. Thanks for staying. And we're going to go straight into a case presentation, so we're not going to do a lot of lecturing. And this case is an acute exacerbation of sinusitis in a patient with chronic rhinosinusitis with polyps. I have nothing to disclose. And so this is a 48-year-old male who presents for his 4th sinus surgery in December of 2018. He presented with a nasal obstruction, loss of smell, post-nasal drainage, and had been treated with the adequate medical therapy that we just reviewed. His past medical history is significant for chronic rhinosinusitis with nasal polyps, asthma, and allergic rhinitis. So here we have our CAT scan, the preoperative CAT scan. We have slices from front to back showing primarily unilateral disease on the left side. So we consider the nasal cavity opacified, the maxillary sinus is partially opacified, and as we go back, we can see how that disease is extending into the nasal cavity and pretty much blocking that left nasal cavity. And further back, we're looking at the sphenoid sinuses, again, subtotal opacification of that left sphenoid sinus with a small clear right sinus. So at the time of surgery, he presents with this picture. On the left side, you see the septum. Right in front of you in the middle is the middle turbinate. To the right of the middle turbinate is the polyp disease. We removed the polyp disease, and now we're looking at what's called allergic mucus. So this is that stuff we refer to as kind of a peanut butter consistency. You suck that out, send it to pathology, and it comes back as allergic mucin. There's positive fungal stains on this, and the cultures demonstrate Staph aureus and a fungus. Preoperatively, the lab showed that the patient had a total IgE of 594 and a diffusely positive RAS panel. So my intention at this point was to get the panel involved. If you had, I'd like to ask Jodi what's she thinking at this point in terms of diagnosis.
I'm thinking allergic fungal sinusitis.
Right. And so what would you say as an allergist to this patient before surgery? Let's say they've just been referred to you. What can you offer them?
I mean, if a patient has sinus disease and significant, assuming nasal symptoms, I usually start with allergy skin testing. I do, a whole panel, but obviously it includes the molds, and just to get an idea, but also to tell them that post-operatively, in order to prevent recurrence, you have to aggressively treat the allergies. So intranasal steroid sprays, and if they are significantly atopic, the possibility for immunotherapy, or as I said nowadays, even a biologic post-op.
Yeah, we'll get to that.
Okay.
So this patient gets all those things you just talked about, and then a year later, they come back to clinic, and now they're talking about right nasal obstruction, right-sided rhinorrhea, right postnasal drainage, worsening asthma symptoms. So they're using their inhalers more frequently. And the endoscope in the clinic looks like this. This is the right nasal cavity, and we see this crusting, kind of inspissated allergic mucin now. All right, so now we have a video here. This is the left nasal cavity. I think this is a nice demonstration of what's normal of what we're looking at compared to what's abnormal. Left nasal cavity, so the septum is on the left. You got the middle turbinate in the middle, and the sinuses are off to the right. So now we're looking again. Left sinus, that's the ethmoid cavity right here. That mucus is normal mucus. It's just recirculating around the tissue, and we were looking into the sphenoid sinus right there. So this is the normal side, and we'll switch over to the right side. That's a hole in the bottom of the cheek sinus on the right. And now we're looking at that crusting, that allergic mucin that's kind of opacifying that posterior ethmoid cavity and sphenoid. And this is looking up towards the skull base and the frontal recess, and again. Okay, so left side, right side. First thing we do here is pull the crusting out and culture it. So that's the debridement that we perform in clinic, where we try to remove all the visible disease in there, and then we end up with this. So this is a nice demonstration of what's normal versus normal on this patient, right and left side. So now we can talk about kind of the treatments. I think the most important thing is getting that stuff out, which is what we call the debridement in clinic. And now we can talk about sprays and rinses, and I'd like to defer to Dr. Rio. So at this point, what's your regimen for sprays or rinses?
So once you've gotten the debris out and ventilated that cavity, if you think that you can deliver saline by way of an irrigation into the sinus, then I like to add a topical steroid to the saline irrigation. So I like to put them on twice daily saline irrigations, and I use a NeilMed sinus rinse bottle. It's a 240 cc or 8-ounce bottle that they can get over the counter. And so just rinsing with the saline is very helpful to wash out the environmental irritants that are aggravating their mucosa. But also I like to add in a topical steroid, budesonide, which Dr. Rubin mentioned she prescribed it to nebulize into the patient's lungs, but we also use it to have the patient squirt into their saline rinse bottle. It gets diluted into the saline. They can irrigate that into their nose. So we do put them on, or I like to use steroid and saline irrigations on a twice daily basis. That's helpful. Then, depending on how symptomatic they are, I may at that point consider an oral steroid as well. If they're not terribly symptomatic and it's something that is causing minimal symptoms for them, then I'll hold off on the oral steroid. If they're very symptomatic, I'll go ahead and give them the oral steroid, and that helps open things up and ventilate it even better. And then same thing with the antibiotic. If they're pretty symptomatic, I'll go ahead and start them on an empiric antibiotic therapy. If they're not terribly symptomatic, I might wait for the culture to come back and see what I want to do then.
So one of the things also in terms of the sprays that we've talked about is, how many of you are familiar with Xhands? Xhands, so this is just Flonase, basically fluticasone, and it's the delivery mechanism that makes this very valuable in our clinic. Flonase doesn't normally get into the sinuses. So this has kind of changed some of the stuff that we do, because now the patient's blowing the Flonase into their nose and this can get into the sinuses. So this can actually shrink polyps. It's somewhat difficult to get approved and difficult to get, but this is another option that we now have that can help with budesonide and kind of cut down on the systemic steroids. One of the things I wanted to add about systemic steroids was when Dr. Rubin presented the asthma, she talked about 5 days. I find that a patient like this will need more than 5 days of steroids. So when they come into your clinic, if you're going to try to treat the sinusitis patient with polyps, it's probably a little bit better to go a little bit longer than the 5 days. Their asthma will get better, but the sinusitis takes a little bit longer. And then we talked a little bit about immunotherapy and the other thing. So Jodi, I thought this would be a good talk, a point to kind of hone in on your biologic modifiers a little bit more. So for this specific patient, what would you recommend being their 4th surgery? At what point are you considering biologic modifiers? Because the Dupixent is a $35,000 drug per year.
Free drug.
What?
They have free drug.
Well, nothing's free. Someone's paying for it.
Yeah, I mean, this is the 4th surgery, you said.
4th surgery.
Yeah, I mean, if they have polyps, we know that the majority of patients, their polyps recur. I do use Xhands as well, but Dupixent is ideal in the patient, in my opinion. These atopic conditions often go together. We have asthma-exacerbated respiratory disease, or Sander's triad. So you see the nasal polyps, the sinus, and the asthma patients. I find that those patients are ideal for biologics. Some patients don't want to do allergen immunotherapy. They don't want to come to my office monthly, et cetera. This is home delivered, self-administered every 2 weeks. So I have talks with most of my patients about this. Plus, we don't find that immunotherapy specifically in the allergic fungal sinusitis patient, allergen immunotherapy to molds might not be very helpful in preventing the recurrence of their disease. So this will target the eosinophilic pathway, block all that inflammation.
So this is an exciting drug in terms of, it got approved in July for chronic rhinosinusitis with polyps. And before that, we didn't have an FDA-approved drug for polyps. But it's very expensive, but it shows that the future, the emerging therapies out there, these biologic modifiers are probably going to make a difference down the road. And I'll stop there, and then we can take questions about this patient or anything else about managing these patients with polyps. If there's no, okay.
I just real quick. So you do the 875 augmentin. Do you do 500 BID augmentin?
I do 875.
Oh.
875 BID. Yeah.
For 7 days.
I do 10 usually. Oh, it depends what I'm treating.
And you can argue that this patient would have done well with just prednisone. As a matter of fact, this is a good example of the prednisone would have worked better than the antibiotic.
5 days.
Yeah, I'd probably do 12.
Tapering dose?
Yeah, I would do 40, 30, 20, 10 each for 3 days.
How long do you put this patient on Dupixent?
So that's a problem with Dupixent.
The question was, how long do you leave the patient on Dupixent?
This lifelong therapy every 2 weeks.
How often?
Okay, it's a shot they do at home, and they get trained how to do it. And the reason for that is there's very little or no little risk of anaphylaxis, because it's the only one of these biologic modifiers that can be done at home.
No.
Oh, really?
Nucala, Fasenra, they're both
Okay.
at home.
Well, that was not. Then the reps are giving bad information.
Nucala and Fasenra can be done at home.
This just goes back to the
actually behave rhinosinusitis. Could you share with us what your topical decongestants would be that you might use?
So I would use Afrin. I would use oxytazoline or Afrin. It's got a longer duration of action than neosynephrine, so it gives me 12 hours relief. I have them use 2 sprays each nostril, BID, for 3 days only. And I really, because you don't want them to get rebound rhinitis, you don't want them to get hooked on the spray, so I'll let them do it for 3 days.
Most of these patients will come to you and not know that they were on a decongestant. The fast-acting, they do not know that's a form of neosynephrine, and that's a big problem because they're using it daily.
If this chronic sinusitis is related to fungus, which will be the first choice, and how long will be the treatment?
So the question was, if it's a chronic sinusitis related to fungus, what would be the first choice of therapy? And how long? And so fungal sinusitis could be a whole, 2-hour session. But there's 3 basic types of fungal sinusitis. There's allergic fungal sinusitis, which is what we're talking about here. That's actually an allergic condition, and the patient's not infected with fungus. They're having an allergic reaction on their mucosa to the fungus. They may get secondary bacterial infections, but antifungal agents have not been proven to be effective in the literature for allergic fungal sinusitis because they're not infected by the fungus. They're reacting to it. The second type of fungal sinusitis is what is called fungus ball in the literature, or a sinus mycetoma. And that is actually just a collection of fungus growing in the sinus cavity. They don't have to be allergic to it. Again, it's not tissue invasive, it's sitting and growing on mucus in the cavity, and that can cause symptoms and a secondary comorbid bacterial infection with that. The treatment for that is surgical. You just have to get that fungus ball and that pus out of the sinus. And then the third type of fungal sinusitis is invasive fungal sinusitis, and there's an acute fulminant type, which is life-threatening. It's usually in an immunosuppressed host. Or you have indolent invasive fungal sinusitis, which is also usually in an immunosuppressed host that can be a more chronic course, and that is tissue invasive, and that is something that requires surgical debridement to get the fungus out because it's angio-invasive into the tissue. And you also will treat that patient with systemic antifungals. And what we're using now in hospitals is amphotericin IV, and then the patient will get switched over to some type of oral agent that they can take home should they survive that event, and they'll get switched over to long-term antifungal therapy, whether it be IV or...
But to stress what he's saying, those first 2 do not need topical antifungals, and they do not need antifungal medication, systemic. The third one is going to be a very sick patient that's in the hospital that will not be in your clinic. So stay away from antifungals, period.
When a patient comes and say like, oh, I've been diagnosed before a positive shows and I'm going to get like chronic fungal sinusitis, you still refer or?
So that patient, there's a good chance they have allergic fungal sinusitis, because oftentimes when you do their cultures, you'll get bacteria and that fungal will culture out as well, but they're not infected by the fungus. So they probably have allergic fungal sinusitis, and that is a chronic disease. We don't have a cure for it, and that's that patient that he just showed. So those patients do need to develop a relationship with an otolaryngologist and most likely an allergist, immunologist as well, so that they can get treated with some of these new, therapies.
So my question to earlier, you're talking about viral rhinosinusitis. You all like steroids and ENT. So in family medicine, what's your thought on us using like a Kenalog injection in someone that comes in with viral sinusitis?
I mean, it's,
I just think, or is it not beneficial at all?
Short answer, I probably would steer clear of it, just because that Kenalog's gonna be active in them, physiologically active in them, well beyond the duration of time that they needed it. So I would just give them an oral steroid. A patient who's got seasonal allergic rhinitis and they're going to be miserable all spring, that's a different story. But that patient comes in with viral rhinosinusitis and acute symptoms, you can give them 3, 5, medical dose pack. That's rare. I usually don't give oral steroids for acute viral rhinosinusitis. It would be oral decongestant, topical decongestant, ibuprofen. Any other questions? You can stalk us afterwards if need be, but I think any other final comments?
Yeah, I do have the final comment here. And, oh, it's not on this thing. I put it on my computer. I had a picture of the Notre Dame beating Michigan, and it's on the wrong laptop. Bad me.
The only good thing about Notre Dame was the movie Rudy.
Well, thank you very much. So I want to just remind everyone, please fill out your evaluation and make sure your email address and your name are legible so that we can get you your CME. Okay, that's going to come to you by way of email. Okay. Thank you.